I'm Dr. Demetrio J. Aguila III. I'm a peripheral nerve surgeon, I'm an ear, nose, and throat surgeon, and I'm also a plastic surgeon. I'm the host and founder of the Direct Care Movement podcast, where we dive into the intricacies of direct care, whether it's direct primary care or direct surgical care. You can find out more about what this movement is and where it's going and where it came from. We're excited today to have Dr. Paula Muto, a vascular surgeon, general surgeon from Massachusetts, on our podcast today. Dr. Muto?
And thank you for being here. It's really, really nice to join your podcast and talk to your audience today.
Well, we're excited to have you on board. Can you tell us a little bit about your background? Tell us a little about yourself before we dive in.
So I'm a surgeon, really by birth. My dad was a thoracic surgeon, a wonderful surgeon. My brother just retired after 41 years, a GYN oncologist. My husband is a general vascular surgeon. 2 uncles are in surgery, and me. So it's sort of like the family business. So I've always been in solo private practice pretty much my entire career, sitting in the front lines of medicine in a poor community next to an affluent community with hospitals that were cannibalizing each other, very similar in Massachusetts, the birthplace of the Affordable Care Act. And then about 8.5 years ago, about 10 years ago, I was beginning to notice things weren't working well and writing a lot of angry letters. And then about 8.5 years ago, I decided maybe I can kind of try to change it. So in my 50s, with my kids off to college, I said, well, what do I do now other than practice surgery? And I started a tech startup called UberDoc, a platform for direct pay specialty care and direct pay physician care, which has now grown nationally and with thousands of doctors. And that's, I think, why we're talking today, because it's the intersection actually of transparency in healthcare and access.
Sure. So Paula, tell me, you had mentioned that you come from a family of physicians, much like I did. My dad's a retired physiatrist, and so I grew up, seeing medicine from the back end before I saw it from the front end. Tell us about that in your experience. How did that influence your career path?
So, watching, my dad was a great surgeon, and he had one theme, like one thing that drove him, and it's just take good care of the patient. That's it. Just do good, because you'll be happy, you'll be financially successful, your patient will be happy, and the hospital will be happy. And that, just focus on that. And now it sounds very simple, but that's sort of what drove him. And my dad was a really talented person. He was an immigrant. He worked really hard in the Boston hospitals to train, which was not easy at the time. He brought in a lot of technology. He was an inventor. He didn't see things that were working well, and he worked with young people in R&D and created a lot of inventions. At the time, we called him crazy inventor. Now you call him an entrepreneur. And so he was always trying to constantly change things. He worked till the day he died. And he saved a lot of people because he just would drop and run and go to the hospital. It was just easy for him to just know what to do and to do the right thing. I think that my brother and I should say my other brother is an informatic pioneer. So in medical informatics. So we're all kind of in the medical world. And I think we were all influenced by the fact that that was the right thing to do. Now, of course, he had my mother who took care of everybody. Right? Like he could drop and run. But I think that the issue is that it was such a easy priority. I'm sure the same thing for you. It wasn't even a question, right? There was no discussion. This is how you practice medicine. You put your patient first, you drop and run, and you take care. And if the hospital isn't behaving, you tell them and make them behave, right? Because nothing is going to come between you and your patient. And I think that that's sort of the world we grew up in.
Yeah, and sadly, some of that, it feels to me anyway, like some of that has changed, particularly as our younger generation of physicians is coming up. That that message doesn't seem to feel so clear anymore. And I don't know, I'd be curious about your thoughts. Is it due to mentorship, or is it these other external factors that's influencing it?
I think in the last, we've been practicing sort of in both worlds, right? Like when I trained in the 90s, well, I guess I finished in 96. It was still you did your patient came first, you took your call schedule, right? There wasn't so much about work-life balance, but we always had a work-life balance. I mean, I had my daughter 24 hours after taking my written boards in the middle of my fellowship, not really perfectly planned. And I did pass those boards, but work and life sort of bump into, right? But I think that with the changes in healthcare, probably brought on by the Affordable Care Act and the privatization essentially of Medicaid, that shift toward the business of healthcare, shall we say, it became increasingly harder and harder to stay in practice with the autonomy that you could put your patient first. And I think that stress created that, we call it burnout, we call it moral injury. And so now we get kids who are growing up, right? Like these medical students are coming in, they're so wide-eyed, they work so hard to get where they are. Many of them are, have delayed entry, right? It's not easy to get into medical school, and they've done other paths to get there. And I think that that is the positive things is that work-life balance is it's more front and center. Mental health issues, the wellness of our residents, really important, right? We weren't allowed to talk about that. But I also think that we're forgetting that some of the frustration that we felt was because we were fighting for our patient. And now we take that necessity to fight away. And I think that's where we're losing it a little bit, because now it's almost like they're not even aware of what their patient is going through, right? So, right. And also in the wake of, in the background of all of this is technology. Like, when I trained, you admitted your patient and you kept them in the hospital for 7 days. And then you took their staples out and then they went home. Right? So whether they lived in a 6th-floor walk-up or whether they lived in an assisted living with, 3 people helping them, it wouldn't matter, right? Because we controlled the outcome. We cared for that patient from beginning, middle, end. Now our patient is 45 minutes in the operating room, right? Then the PACU, then home, right? Those social determinants of health now are much, much more important to the outcome. Not only is it that we don't see that what happens to that patient, right? Like that, the resident isn't now feeling the pain of that patient, right? Not seeing that they can't urinate or they can't do, they're not. So that piece is sort of missing in their exposure and their experience and training. But also we're not really cognizant of the cost and the struggle that these people have, because maybe their spouse has to work and left them alone, or maybe someone has to take a week out of work, or somebody has to change their whole, take family leave or something that impacts the economy of that family. So I think that part of it is just the exposure that residents get now is different from us, right? We got to the privilege of watching those patients and figuring it out. And I think now they're just one step removed. And in some ways, it's only that 45 minutes, right? So what do I have to care about that patient? 45 minutes, I'm done, right? I'm going to go to the next OR and next patient, right? They're just body parts. I shouldn't say billable events.
But that seems to be the phrase of the day, doesn't it?
Yeah. No.
Yeah. Now,
and I just think that's part of the technology, right?
Sure. And a whole bunch of different influences that somehow or another got out of our control.
Right.
Now, you'd mentioned earlier, and I think it sounds to me like these things tie together. You'd mentioned to me that this transition that you made in your career, in the last decade, was prompted, at least in part, by a bunch of angry letters.
A lot of angry letters.
So let's talk about those angry letters. What were you angry about, and what were the letters about?
I kept, I see the world different. I in the sense that people argue about healthcare, and they start with value-based care, managed care. I start with the patient, and I am a fervent believer the patient can manage their own care. I think we are in an archaic system built in the 1960s, let's be honest, right? Where your employer, because of a World War II initiative, right? Right? Employer benefits came because Truman said, we don't want you to steal factory workers. So in order to attract you couldn't raise their salaries. It was a wage freeze. They said, well, let's offer benefits. And they just kind of stuck. And now your employer is like mandated to provide your health coverage, right? So I see the world really differently, because back in the 60s, once again, the doctor knew what was best for you. We had a very paternalistic model of medicine, slightly misogynistic as well, where, again, you're talking to a woman vascular surgeon, and honestly, when I went into practice, we didn't worry about women's carotids because women didn't have strokes or heart attacks, clearly. We didn't even get colon cancer. Only men got, right? I mean, so there were like lots of gaps in the way we inherent biases, shall we say. So, but that's not our world now. Our world now is our patients are our partners. Like, we're meeting not in this hierarchical, we're meeting it sort of on the same latitude, right? And they talk about meeting your patient where they are. That's what it means. It means that, like, okay, I'm going to prescribe this for you. How are you going to get it? Right? Or I'm going to do this operation. How are you going to recover? Right? Like, I have to know a lot more about you and where you live and everything else, because what we talked about a few minutes ago. So my angry letters were always about, like, you're missing the point. You're missing the point. We're trying to fix a system that was built in the 60s to solve the 1960s problems. We are not focusing on where we are today. Right? And where we are today is breathtaking technology. In my own lifetime, where, like, I used to take a patient to the OR for 2.5 hours. I do it 8 minutes in my office. I don't even operate on your carotids anymore. I give you a statin, right? I mean, like, so many things are just different, right? Better, faster, cheaper. Your cancer care. Think of your cancer therapy. It used to be you'd be in the hospital with a special line that we used to put in and get those infusions, induction therapy, and everything else. And you'd have to be on reverse precautions. Remember those days, right? Yes. Now you're at home with a bottle of pills that were probably made just for you, or you and 5 other people, right? They're so, we're taking your genetic footprint and putting it on your cancer therapy. I mean, that means that the delivery of that care is at home. Again, I'll go back to, you're opening up your own bottle. You're not like, so I think that we have to think about our healthcare system and where the dollars need to be. And I think they need to be squarely with the patient, just because that's where the patient's going to get 95% of their care. And we need institutions. I'm not saying we don't, but I just think we need to focus that. And when I think about healthcare, I only hear about institutional answers. Let's build more buildings. Let's consolidate. Let's do some more managed care. We need a lot of layer, right? Managed care. We need to manage your care even further, right? We need to take more of that healthcare dollar away and manage it. And I wrote a lot of angry letters saying, but you're not seeing where medicine is, the technology is, and where our residents, where they're training and what we're teaching them to do.
Right. And, when you consider that, I was reading some statistics recently, and, less than 30 cents out of every dollar spent on healthcare in the United States these days actually goes to the people that are providing the care.
It's the pie, it's called the Pac-Man chart, right? And that's from, like, 2018, it was like 77% is going to manage the care. Or 27% to the patient and the doctor or the nurse and the medication, and the other 73% of that pie. I'm going to say that's close to 80. It's the 80-20 rule. And it's ironic because Obamacare, the Affordable Care Act, capped that medical loss ratio at 20%, which means that 20% of the healthcare dollar was supposed to go to overhead and 80% to the patient. It's a complete reversal. Complete. And it's getting worse. And no one apologizes for it.
Right, exactly. And it's a system which is really, in many ways, like you said, it's archaic. I mean, it started with those the wage freezes, which, ultimately, I think the real turning point is on that CMS form, which is now electronic for most practices and hospitals, that assignment of benefits box. When you sign in that box, any connection that the patient has to the cost of care is completely lost, because the patient no longer sees no longer sees the transactions, that they're no longer,
But remember, we brought that on ourselves.
Oh, we did. Totally.
In the 1960s, it used to be you'd go to the doctor, you'd have your appendix out, and you'd pay the doctor, and they'd give you a bill, and you'd submit it to Blue Cross Blue Shield for reimbursement. And then Blue Cross said, hey, I tell you what, would you like us to collect the money? And the doctor's like, oh my God, that's so much easier than collecting it from the patient. You will collect it for us. and the doctor said, okay. And that's what happened, right? So the patient became exactly like you said, very detached from the cost of their care, right? They were completely, but also at the same time, I'm going to tell you, the doctors became detached from the cost of care. And in the last decade or so, as we've seen increase in patient deductibles and co-insurances, where patients are becoming much more aware of what their costs are. And depending on where you practice, whether you practice independently or whether you practice as an employed doctor, your motives are very different, right? You could be in the OR and say, I'm going to add this in, because it's like, for example, when you're a surgeon, there was this you code, right? And you can say you take out someone's colon, and there was a code for take down a hepatic flexure, right? We take down a splenic flexure. You got to take it down. I mean, it's part of the surgery. It's not like sometimes you get away without it, but for the most part, it's part of the operation. So people got really into coding, right? Oh, it wasn't just a colectomy. It was like all these extra codes. The funny part about all that is that if you actually followed the code, followed the claim, you didn't really get paid. Maybe got $6 extra, $12, and the funny part about it is that the claim immediately derailed because now it had an extra code on it. So now it goes into the off ramp and sits in the adjudication pile. So now you're guaranteed not going to get paid for at least 90 days, right? And then, of course, your billing service and your billing person and your office has to provide so much more information for to get paid. And now whatever $12 you were going to collect, you've spent $25 to get it, right? Now, in an employed model, that's an RVU. And, when people talk about this, Marty Macri actually talked about this, the chase for the RVUs, right? Like you really... And so all of a sudden now a young surgeon is saying, hey, I'm going to get paid if I do this. So I'm going to add as many codes on here, which is fine because you're adding them in. But the irony is that, first of all, no one's collecting any of that. And unfortunately, some of that does now trickle down to the patient. So that extra code that you put on there is causing a patient to have to pay extra out of pocket for a bill that they probably can't afford anyways. And so that's sort of like, not nice to the patient.
Yeah, to say the least, right?
And the systems don't really benefit either, because even your boss is now not your institution is going to get a delayed payment. And I'm saying all codes are bad and codes are important, but it's like, it gets to diminishing returns.
For sure. Well, and, I think that was for me, that was kind of the straw that broke the camel's back. I got tired of patients coming and yelling at me for the coding and the billing, which, in many cases, I didn't have a whole lot of control over. I mean, sure, maybe I said, okay, 64787, 64784, but then they'd say, oh, if I had known it was going to cost this much, I would have reconsidered, and they're yelling at me for how expensive it is. I was like, I'm not the one that decides how much this stuff costs. And
but at the same time, though, the behavior is sort of like, it's understood because, Medicare, the government comes in and says, we're going to cut Medicare. Hey, that's your bread and butter for most of us, right? Medicare is a big part of our, it's 2/3 of our patients and it's 1/3 of the payment, right? So we need that. And to survive. And then they kept cutting it and cutting it and cutting it. So it's like, $52 for 15 minutes. You might as well drive an Uber. I thought, gosh, you're going to get $32 an hour now. It's like, come on, that's ridiculous, right? And you have to pay your staff, right? You have to pay, and so what did doctors do is they started adding things in. Well, if I throw an EKG in, if I do this, if I do that, so in fairness, the lack that when you drop the payments, the increase in coding came from a true economic need. It was to be able to stay even keel. The problem we've seen now in the last 4 years is that with the Medicare cuts on top of inflation, you put people below the waterline. So now to put a stent in an artery, okay, whether it's a femoral artery or even a coronary, you know what the margin of that is? negative 22%. Like so no matter what you do, you're going to like basically pay for the patient to have it done. So when the cardiologist starts jumping up and down, interventional saying, I need a new suite because I want to put in these brand new stents or I'm going to leave. They're like, oh, okay, bye. Seriously. I mean, I hate to say it, but it's like, you're going to lose talent because they look at it's a business model in the boardroom and they're like, hey. But so what does that mean for people having, acute coronary occlusion?
Sure.
Or still, you know what I mean?
Yeah.
It's like,
well, I mean,
right?
Like I started out in ENT and, one of my mentors who I respect tremendously, he's a general surgeon, specializes in laparoscopic surgery. And he told me if he had it all to do over again, he would have become a dentist because, he paid more. Like, I'll give you an example. This is the example he used with me. And, I kind of massaged it a little bit to apply to my scenario. I could do 4 tracheotomies and get paid the same amount as I paid my dentist for my last root canal.
Well, again, it comes down to the doctors not understanding, right? Like, again, I shouldn't say that you understood what coding, billing, and collecting. It's just that over the last decade or so, you weren't collecting. You were billing and coding and doing the work, but you weren't collecting. And that was intentional to herd us together, like, herd us over a cliff in terms of, because they want to, into a employed mob, right? And it wasn't necessarily in preparation for Medicare for All. I mean, yeah, everyone talks about that, but we're already there. I mean, the insurance companies is 69% of their revenue, and that was in 2023. Probably comes from taxpayers. So the majority of the profits of an insurance company are actually tax-paying dollars. We forget how heavily subsidized they are. So like kind of we own United Healthcare, like the voters and the American public own it, the taxpayers. So Medicare for All is another 11%. So I just put that in perspective, right? But I think that we have been herded over the cliff. And so people either had to consolidate, join other doctors, become a bigger group, which is a bigger overhead and more complications and more, harder to practice, or get support from the hospital. General surgeons had to get support with call pay. In fact, that was my thing. I really fought hard for our surgeons for call pay, because you needed to have call pay for trauma call, for emergency room coverage, because you'd come out, you wake up in the middle of the night and take care of a patient that was, that was either a Medicaid patient or maybe perhaps had no insurance, and you needed to have, and you sometimes had to give up your office hours to do that. And that just wasn't an equation that made any sense as the general surgical reimbursements were dropping precipitous, So I think that the problem is, why did the reimbursements drop? Why didn't we have a fight? I can go a long explanation, but from the 1960s, where we have this old system, we also have no trust to physicians. Physicians do not have a voice in Washington. They have always been accused of, again, that behavior. You cut my Medicare, I'm going to see twice as much. I'm going to do twice as much. It's a behavior that every other business does. But in medicine, it's considered like, that we're painted as but the funny part is the voters don't pay test that way. The patients put us as the highest trust.
Right. Exactly.
Right. So I think that's sort of the narrative has to change from the top down when it comes to doctors, and physicians also have to go from the bottom up and defend their patients.
Yes, we absolutely have to be advocates. So then that leads into the next question. What was your breaking point? What was that straw that broke your back that finally made you decide, enough of this, I'm doing something different?
So when when you talk to physician entrepreneurs, which I guess I'm one of them, there's something that gnaws at you. You don't just wake up one day and say, I think I want to be an entrepreneur. It doesn't work that way. You have something that is inside you that you can't, it's a fire you can't put out, right? And you just keep thinking about it. You write those angry letters. You want to be heard. You want to be heard. You want a voice. And I think I started UberDoc to get a voice. And as my voice gets louder and other people listen, they're saying, oh, wait a minute, she's looking at it differently, right? Like she's looking at it with a different lens and looking to the future. And it's like, and if the idea is good, I mean, honestly, UberDoc was the easiest idea in the world. Find a doctor nearby available, push a button, make it in person or telemedicine, find a specialist. And a specialist defined as both, as any physician who's done a residency training program. So a specialist in internal medicine, family practice, pediatrics, primary care is a specialty. Oh, we forget that. So we unify all doctors, right? Specialists. And to try to pivot toward that cash model. Just give me one seat in your waiting room next to your Medicare or Medicaid patient. Give me one seat that's cash. That's it. Just give me one seat in your waiting room. My goal is to have every seat in any waiting room. And so that was I think it was just to kind of nod at me. And then I put a bunch of smart people in a room, doctors, managed care people from the hospital, nurses, informatic people. And I said, I have an idea. And they're like, oh my God, that's such a great idea. And that was how it started. And so we built it. And now I'm very proud that, UberDoc's biggest customer are actually veterans, disabled, people who serve, like they can't get in. Like we're the appointment maker, right? We give you priority access and who's using us right now? The people who served us. Like we're providing service to the people who served us. So I guess it just sort of, again, you kind of can't rest and then you have to have the opportunity, and it's a challenge. I talk a lot about entrepreneurship. That's a whole other conversation. You need to be in a position in your life where you could take that financial risk to be able to do it. And I've continued to practice because I think that's the most important thing. To being in front of the patients and listening, you got to listen. And learn from everybody around you. And that's the great joy of UberDoc is I've talked to doctors like you, doctors all over the country, people who don't practice like just surgery. I'm just not in my little silo, right? Not just Massachusetts, all over the country. And I talk to employer benefit brokers a lot. I hear what they go through to get coverage for their people. I talk to board people. I talk to insurance brokers. I talk to patients, and it's all so. So I guess what was the straw? I think it was just that restlessness that you wanted to be heard.
Sure. So let's give you a platform to be heard. Walk us through the mechanics of UberDoc, both from the patient perspective, and then obviously for our audience from the physician perspective. What's so different about UberDoc that addresses the underlying problems in our healthcare system?
So the single thing that makes it really, two things that make it unique is that, you find a doctor nearby available, make an appointment. We made it the level of a fourth grader for both the doctor and the patient. So first of all, it's simple technology. It needed to be simple. You didn't want any obstacles to connection of a doctor and a patient. So again, doctor, you heard it in my voice. This is about the doctor-patient relationship, right? This is about getting to the right doctor right away and get your problem solved. So the patient just finds a doctor nearby available, requests an appointment. If the doctor says thumbs up, they don't even have to, they just have to say thumbs up, an emoji. And immediately they get $50 is taken from their credit card or health savings, and it goes right to the doctor. If the patient doesn't show up, the doctor patient forfeits the $50. So that's part of this equation. There is no insurance. There is no, there's no information taken. There is no data collection at all. We take nothing from the patient other than their chief complaint in their own word. My right thumb, I have trouble sleeping. I think I have sleep apnea. I have I want a second opinion on my breast lump. Whatever that is, it's in the patient's own words. And that's the only information we take. So two things were very simple. We are not insurance, so we don't take anything, and we take no data. So we don't integrate with electronic records at all. So on the doctor side, you get that ping, and a young doctor gets it on their phone saying, "Hey, my wrist hurts. I may have a carpal tunnel," and you're a young hand surgeon. And you're like, "Oh my God, this is great." And you can accept the patient and not get yelled at by your front end, who's like the Krabby Patty saying, "Why didn't they get a referral or an authorization? They're out of network." It's like, oh my God. It's like, I just trained and I really want to cut somebody. No, I really want, right? you get these young doctors. I mean, right? They're really excited. They want to be, engaged with the patient. So that's sort of the exciting part about it. It makes it really seamless. Now, in deploying it, independent practitioners, fabulous. In small multi-specialty groups, fabulous. The moment we go up the chain to hospital employed doctors, it gets harder because their central scheduling is offsite, right? Which is unfortunate. It's all data that's collected and not necessarily protected and way offsite, which means that the people in the clinics who have to deal with the poor person who shows up on the wrong day, right? The person who shows up and says, I'm sorry, oh my God, my daughter just drove me. I thought my appointment was, this week. They get turned away, right? Because they don't have any way to put them in the scheduler. Like literally Epic has windows only open to these third-party vendors that isn't all secure, by the way. But so I think that the workflows are really tough for access. It doesn't necessarily reflect lack of availability, but lack of utilization. So patients, our platform has a practically zero no-show rate because the patient's, and if patient doesn't show up, they lose the money. So UberDoc doesn't charge doctors to be on the platform. We only take a transaction fee at the time of it. We set it at about the same price, and doctors can set their price. We don't set the price. We put guardrails around it. We say, I don't want to see you less than $150 because you're a doctor. I don't want a $15 visit. That's not you, right? That's a brand. They're UberDoc. We're better, above everybody, right? But I don't want to see you over $500 either because that's like in the danger zone for patients, right? So I want you to be available. I want you to be price transparent. I want to flip the access and the cost equation upside down. And then once the patient's with you, we have nothing further to do with that. If they need to have surgery, they need to have an X-ray, an MRI, whatever, they can pull out their insurance card or they can resume cash. But UberDoc has done their job. We're like open table. We got you in the restaurant. You can order whatever you want.
Sure. Well, that's awesome. So, and one of the things, I mean, you just hit the nail right on the head, I think, for the paradigm shift, because that's what we're talking about here, right? Is a change in the way we look at things. And you said open table. I mean, I think those of us that aren't already doing this, we need to start thinking about medicine in much the same way that any other business owner thinks about their business, like the restaurant owner or anybody else. And you say, okay, how do I attract people to come eat at my restaurant?
And remember, this has to do with the internet, right? So as a vein specialist, so I'm a vascular surgeon. I have a vein center that I've had for umpteen years. I needed to advertise to my patients. I learned early on that it was going to go beyond my little network, which constantly shifted, right? In Massachusetts, I'm a Red Sox fan one day, I'm a Yankee fan the next. It's the network's lines are constantly crossing, right? So you just need to be front and center to your patient. And one of the things that we also do for the doctor is that we give them a landing page. We give them their own web page, their own website that they can edit themselves and tell patients all about yourself. So that's very expensive to have your own website. We give that to the doctor. All I'm asking for is a transaction fee. And now we have a Hero Serve program, which is a bigger program for the government, which we can take people who are advanced practitioners, physician assistants and nurse practitioners who want to help do these exams. We have lots of them. We have specialty exams. We have, ordinary exams. We have primary care exams. We got a lot of exams, and we need a lot of doctors. And so we really, really encourage people to join Hero Serve as well. It's it's very satisfying to be able to serve those who served us. But again, I agree that doctors have to be smart. They have to be front and center to their patients. They realize Dr. Google is probably the best referrer out there, right? And I think that the patients are wandering the desert, literally. They don't know where they're going, and they end up in an urgent care, which can cost a lot, or an emergency room, or And wouldn't it be great if they could just come, directly direct their care, because gosh, they're smart. They can manage their own care.
For sure. Well, and I think, asking patients to take responsibility empowers them. I think it
That
gives them that sense that, they're not a victim anymore.
right. And I think that a lot of health plans are recognizing that it's much more convenient to just give your employee, here's a health savings account. Go and do all those Medicare Part B stuff on your own, and we'll cover when it's something, right? I mean, really, there's a lot of processing fees that go with small claims, right? Processing those E&M codes, it's expensive for the insurance companies too, and for the TPAs, and for the employers, and for these health plans. It's like, and they're like, we got to collect the data. It's like, do you really need the data? Like, what's the matter? You have this, like, what data is going to inform anything? It certainly doesn't lower prices. And we won't even get into how the brokers work and all those transaction fees that they take every time you have an encounter. So employers really, when they're smart, realize, whoa, if I give my employees UberDoc, they're off the grid, right? We can eliminate about 50 or 60% of all claims, just sort of poof. Oh my God, right? Because they've gone for those doctor visits, and you're not paying for those.
Yeah, put the patient in charge.
Right, and then this is where the narrative has to change. Where, oh my God, how that patient's into that ENT doctor, they're going to do unnecessary surgery. I haven't met a patient yet who walks in the door and says, "Please operate on me."
Yeah.
I really feel like I need something taken out of me today.
I don't know what it is, but just do something,
Yeah, exactly. I mean, that's another narrative that we have never been able to change. But I'm okay with, again, when we change the narrative and change the concept, because medicine's changed. And the doctors have to meet the patients where they are. And we start with that. We putting the healthcare dollar not in our hand, in the patient's hand. Right? Don't pay us more, cost us less, but give the patient the dollar. And let them pay you.
Right. So as we tie up here at the end, and by the way, this has been an amazing conversation. Thank you so much for joining us. Let me ask you the key question that everybody's waiting for. When, obviously you've had a lot of experience. You've had this amazing journey. What's the one thing that you now understand about the business of medicine and direct care that you wish you could tell your younger self when you were a medical student, a resident, a fellow? What's that one, what's that thing that you wish you had known back then?
I wish that I had seen, understood more about how the system was rigged. I think that if more of us understood, we would have stood up a lot louder sooner. I think my younger self would have been like, we all enabled it. We're enablers, right? And it's not just about the coding and the billing, but we made adjustments every single time they told us something. We made an adjustment. And I think that if we rolled that reel back and replayed that, we would have put our line in the sand and said no.
I agree 100%.
Yeah.
So how do people find you?
I'm very easy to find. They can find me on LinkedIn. They can email me, paula@uber-docs.com. I'm very accessible anytime. I love young people, especially residents, medical students, pre-medical students. UberDoc has had fabulous interns who have all, few have gone into medical school. Some have gone into healthcare. Some actually went to go work for United Healthcare. I'm sorry, but maybe with a better understanding of like what patients go through, right? And Epic and all sorts of other, the healthcare industry is a vast industry. And the technology, building a site platform, I encourage young people to look outside their world, right? They get very focused as a resident. Oh, I've got to do all this and I have no time for anything except my personal life, which is great. But there's a big intellectual life out there that's bigger and better and faster and great when you take the blinders off.
Yes, for sure.
And you hear, and I think that's so I think for the young people, we're doing this for you.
Right.
I'm going back on call actually, as I've been off call for a few years, and they're paying me again, so I'm going back on. That's it. And we're a little bit short on surgeons, and I'm most excited because I'm going to be back in the OR with the rest.
That's awesome.
On a more regular basis. So I only see them once or twice a week now, but now I'm going to see them.
That's awesome. Well, thank you, Paula, for joining us on the podcast today. It was so exciting to have you on board and to hear so much about Uberdog and all the great work that you're doing. Thank you for joining us on the Direct Care Movement podcast. We're excited that you joined us, and we're looking forward to having you join us in future episodes as we dive into more questions and more concerns and more solutions in the direct care space, whether it's direct primary care or direct specialty care. If you liked what you heard and you want to know more, please click like and subscribe and leave us a review. And don't be afraid to reach out to us directly so we can get you more information about direct care, whether it's direct primary care or direct specialty care.